call upon Dr. Soba to please talk to us about cost-effective and resource-efficient screening.
I think a lot of mine has been already covered, so I'll be pretty quick. So at present, in the world, we are only treating 6% of the patients with diabetes for vision-threatening complications related to diabetic retinopathy. So it is this 6 million that we in India trying to triage and get treated. So when we already discussed this, so this morning GVS just mentioned we have just over 100 million people with diabetes in India. So if you look at it in relation to UK, I'm in the UK now, we have 60 million population in the UK. So India has more diabetes than the population of UK. We are very proud of 80% of our patients with diabetes having screening in the UK. That means we managed to get 4 million people with diabetes screened annually. Dr. Kim has just said he did 1 million in a small area in Tamil Nadu. So this is the contrast. So we cannot compare NHS system with what we deal with in India. So our biggest problem is 101 million people with diabetes. We need to find who are these 3 million people with vision-threatening diabetic retinopathy. And it's like, trying to fish from a big pond of diabetes people, right? So that's where I know we are doing a fantastic job here, doing a lot of opportunistic screening, etc. But we need to be quick. We have to identify who these 3 million people are. And for that, we need to find out other ways rather than universal annual screening. Now, GVS mentioned our study. We did the Smart India study here. We have given we have had publications just to show that the Indian government of India that we need to implement policies for to identify the 3 million people with vision-threatening diabetic retinopathy. And we also gave the government of India the cost pressures they will go through. It is 4,230 crores if we do universal annual screening for patients with diabetes in India. So that's not feasible, even in the richest countries. So we need to find out other ways of doing it. So this has already been mentioned, who to screen. Of course, ideally all patients with diabetes, but we will not get there if we do it like use universal annual screening. When to screen, we will cover that. And how to screen, I think the whole topic till now was how to screen, and you have given a lot of good models. We did a study within the On It India program about serum cystatin C. So if you do this blood test and know the patient's age, ethnicity, duration of diabetes, and an HbA1c, we can detect about 80% of the people with vision-threatening diabetic retinopathy. So this is just a simple test that could be done if there are no cameras around. Now, even simpler is we do risk modeling to find out who should be triaged. Very simple parameters like duration of diabetes, age, gender, and what medication they are on. If they are on insulin, they need to be screened. Yeah, and if they are on 2 or more drugs, they are also oral hypertensive drugs, they need to be screened. So when you look at risk-based screening, this is just to, I'm not saying this should be followed, but it should be followed now to capture those patients with VTDR. So if a patient has less than 5 years duration and they're more than 50 years old, but is on insulin, they need to have their annual screen because they are high-risk individuals, fast progressing patients. 5 to 15 years of diabetes, no matter what age, if they are on insulin or on 2 anti-diabetic drugs, then they have to be screened. And then more than 15 years of diabetes, and if they are on any treatment, because the duration of diabetes is, of course, the bigger, strong risk factor for this. So when you screen these, if you look at only these sort of patients for immediate triage to a screening unit, we may capture that VTDR patients pretty quickly. When we go to hospital-based screening, everyone said the importance of physician screening, primary physicians and diabetologists. And the question was, how do ophthalmologists help? And I think Dr. Padma just mentioned how well we can help one ophthalmologist helping a huge diabetes telemedicine project. It can be done. And also vision centers. Dr. Kim mentioned that all of you have large vision centers that can do. The reap from the vision clinic, as Dr. Kim said, for vision-threatening diabetic retinopathy will be less. So we only have 12% of patients with diabetic retinopathy, and 4% with VTDR. So if you are doing vision clinic, yes, it is good to put the infrastructure in, but today if you want to catch the VTDR, it should be the diabetes clinics. And then of course teleophthalmology is a must, and I think many units, I've been visiting many places here, and they all have very good units. And I think with the onset of artificial intelligence, we are really on a positive stride to manage this problem. We also worked with a Remedio camera with this automated offline AI integrated smartphone camera. The importance of this is because we have done it without AI, and I just echo what you said. 35% of the patients were found to be having VTDR in Kerala in family screening units, but only a third of those patients attended the referral center. And when the people who attended were those with cataract, because they noted their vision is down. So it is extremely difficult if we don't have a way of talking to the patient almost instantly, and that is why AI is very important. So this is the Nayanamritham problem that we discussed. So in Kerala, we did this in the Trivandrum district alone. We involved 16 family health centers and installed Remedio cameras with teleophthalmology, because at that time we did not have AI. The government bought us. That is why we managed to make it successful. We worked with the government. We asked them what protocol is possible. They also came up with the problem that we cannot do mydriasis, right? So we then went back to the government. If they cannot dilate, what can we do? They suggested, they wrote a policy to the district, to the hospital, primary care doctors. The doctors should sign the prescription. So unless you have some leadership at the top telling us, we can give the guidance to the minister or to the health secretary. If they want to then implement, it's that one person who can change the position of every state. So with AI, of course, we have faster analysis possible. We can talk to the patient. Advocacy is stronger, and it's scalable. Of course, as mentioned already, there is regulatory challenges, there's cost pressures, and also with different AI integrated cameras, there are different financing reimbursement issues. And also data privacy, we mentioned that. Poor infrastructure. I mean, it wasn't easy to implement this in Kerala. I mean, I had sleepless nights just working from the UK. I felt like this is going to collapse every other day. And ICT computer training is very, very difficult. And of course, after all this, governance is a major issue. I'll just say why UK, UK is 25 years ahead of diabetic retinopathy screening than India. When I first went to UK nearly 30 years ago, it was just the same like here. There was no change, no universal screening. We all had ophthalmologists doing screening, optometrists doing screening, no register, no diabetes register. It took time. So this is what we are saying. It took 20 years to build up and be very proud of it today, and significant investment went into that because there were a lot of lobbying with the government. The one thing that worked was incentivization. So the GPs or general practitioners, if they did not send the patient for screening, they would lose money. So that sort of incentivization is very important here. I know money, it might be challenging here, but we can think of other forms of incentivization, especially with patients. If the pharmacist doesn't give the medication to the doctor, that's a way out too. So thank you very much. I just gave some ideas, okay?
Well, she allowed me to make a comment here. Why did Kerala succeed? And because this kind of program, which Soba talked about in other states also, including Telangana, Andhra Pradesh, Odisha, etc., because one, people get education in general education in Kerala is higher, not because small population. There is a GDP-wise, they are higher, and GVS talk about the ETL, they are higher ETL than compared to some other states. And also there is a good workforce. But ultimately what helped, what Soba talked about is the policy planning, health policy changes. That was very important. Otherwise, unless there is a political will and health policy changes, most probably, it doesn't matter where you are, you are less likely to succeed. So people are sitting here and working close with the governments would make an effort to make state-wise or country-wise have some kind of health policy change that all diabetic must be screened through the governmental system or a government private health system. That might actually help to do the. Padma talked about something which I somehow or other never liked it. It's called makkal tedi. Go and chase people. So don't have to, because today what you did in 1940, you do it also in 2024, 2040 is not correct. So they have to encourage people to come to the doctor, then doctor going it. Obviously they cannot come all of them. So model which WHO has always suggested that go down the level from tertiary to secondary to primary level. If you can go nearer, have a fixed facility, then might work well. Many times Tulsi have spoken to Tulsi tell that Arvind does a lot of eye camps, but then population coverage through eye camp for Arvind is 7% compared to 80% coverage through their vision centers. So model should be in future, next 20 years time or so, at least in a more accessible place in part of the India, not actually northeast or far east, far states, to have more and more vision centers or primary health center, NCD clinics, etc. That is the future, not the makkal tedi. Makkal tedi is a political slogan. Get vote, but don't get people actually.
Yeah.
It is a government program.
Agreed.
what's
Kanti
saying,
Velugu, makkal tedi, all are government program for the votes, not to actually help people.
Yeah, what sir is saying is true. I was just talking to our DBCS head the other day, and he was saying that after this started, lesser patients are getting screened because they are getting the medicine at home, so they don't come for their screening in the government system. So yes, things can, yeah. So it started during COVID and has continued. But yeah, these things can be a barrier rather than help.